All right. It looks like we're sharing our screen already, so you can see something behind me. And I'll try to sort of stay out of the way of the TV screen. Welcome to this wonderful event from Southern Hills Hospital in the midst of the COVID-19 pandemic. I very much appreciate that you are with us today. In addition, I'm very appreciative of the hospital lending this opportunity to me. I am a robotic spine surgeon. My name is Kornelis Poelstra. I've been a spine surgeon for about 16 years now, and recently just moved to town and joined the staff at Southern Hills Hospital via the practice from Dr. Grover. Some of you may know from Allegiant Spine and the Nevada Spine Clinic. I'm an avid believer in modern technology and advancing the care that we've been providing for so long already to our patients. And for the past decade or so, I've been involved with a variety of robotic development projects. And actually, I'm quite proud to say that I was able to help develop the system called Mazor X, which is a robotic system that just 2 weeks ago landed here in Las Vegas as the first hospital in Vegas. Southern Hills has that available, and as the developer of it and user of it, and having done more of these robotic spine cases than anybody else in the world, I'm very excited that they have embraced this and see that this is the future. So what I would like to share with you today is sort of our roadmap that we've had so far to build this robotic system, as well as what the robot potentially could mean for all of us here in the community. What I can do with the robot better than I would be able to do just with good old handiwork and hammers and chisels and so on, as we used to do our spine surgery, and that we've made a transition into much more minimally invasive spine surgery. Now, everybody nowadays is a minimally invasive spine surgeon, right? So the definition is somewhat gray, but I will share with you some things and show you some images where hopefully you'll better understand what that truly means and how it can help in the recovery should you ever need more than conservative care for a spine problem with maybe some leg pain, some back pain, and some difficulties getting up and around. The second part of the talk actually will be quite educational, because I always think that instead of sort of showing, hey, look what we can do kind of thing, I think it's very helpful to get something out of a talk and walk away with knowledge about what the spine is supposed to look like, and potentially what... Okay, my video camera suddenly got moved, and I think we were doing pretty good to this point. Hopefully this didn't disturb it all that much. So the second part of the talk will be educational about the balance in space and how what we do can actually tremendously affect the outcome of spine surgery simply by getting you back upright, so you don't have to scoot around on a shopping cart in the Lowe's, the Home Depot, the Walmart, and so on, as you see people do, unfortunately, when age sort of progresses and we develop degenerative disease. So without further ado, we're going to talk about robotic spine technology and the improved quality patient care that we can't just say that we would like to do, but we actually have very good evidence, and I'm going to share that with you. I'm excited to do this for Regency. I just moved here right next to Mesa Park, so we're sort of neighbors, and I'm close to this hospital, so community is important for me. So I'm excited to start out in Vegas with a lecture for all of you. I'm an orthopedic boarded spine surgeon. I've also done ortho and neuro in combination, so I'm not neurologically, surgically boarded, but I have done the spine training for neurosurgery also. And you can find us at what we call the Robotic Spine Institute of Las Vegas, which we just started. So let me get the talk. So a little bit about me. As you can hear, I have still a little bit of an accent. I completed medical school in the Netherlands, a small country, as you guys know, up north, where it's somewhat cold and we have lots of water and canals and so on. Lots of tall people. So I'm about 6'6" here standing in front of you. That gave us some difficulty with the camera. But after I completed my medical school, I got the opportunity to do my further studies in Northern Virginia. So I actually went to a town called Herndon and Reston, right south of Washington, DC, and collaborated with a research institute there, as well as in Groningen, my hometown in Holland, to get a PhD in biomedical engineering. So I'm sort of a tinkerer. and I like to develop things, including implants and robotics. Then I was in Charlottesville for my orthopedic residency, and subsequently did neurosurgery and orthopedic spine fellowship in Philadelphia at Thomas Jefferson University. It's inarguably the best spine center to train for spinal surgery. So I was very, very excited to graduate from there, and then stayed on the East Coast for 4 years at a place called Shock Trauma in Baltimore. It's the largest spine trauma center. It's about a 1,600 bed facility, and I really honed my skills there with all the trauma that came in. And we'll look at one or two of the trauma cases also to sort of show what we have been able to do with minimally invasive spine surgery over the past 15 years or so. When it was kind of difficult to raise a family in Baltimore City, we decided to move to Florida. We had 4 small children at that point. So from 2010 to just last year, I was at Sacred Heart Hospital on the Emerald Coast in Destin. So some of you have maybe vacationed there or know people that vacation there. Beautiful white sandy beaches and blue water. So it was wonderful there for 10 years. And we established a complex spinal center, true referral place where people came from 5-6 hours away. I was able to get a robotic spine system there, and then started the development of this Mazor X since 2014. It was truly what you can consider like academic spine surgery, all the difficult stuff that in the Southwest area people had a hard time doing in Florida and Alabama and Southern Georgia, came to me, and I transitioned in 2020 to Silicon Valley for a brief period of time to further the development of the robotic systems, and then joined Allegiant Spine just last month with Dr. Grover, and at the Nevada Spine Center, and now the Robotic Spine Center of Las Vegas, associated with Southern Hills Hospital. We try to bring this new technology to Vegas. It's a very large growing community, and there's not really anything, the robotic spine being done at this point. So these are some of the cases that hopefully none of you will ever have to have done, but this sort of shows the gamut that we go through. Very complex spinal reconstructions of the neck in people with cancer. We take out the spinal column and stabilize it with cages and rods. Sort of nightmare things that I inherited from different places that, because we saw so much of it, we got very good at fixing. And then, the scoliosis type correction surgery with multiple rod constructs and so on. So this is not bread and butter orthopedics. This is not bread and butter spine surgery. This is highly complex material that we are capable of. And we try now, if this is necessary, to do this with more minimally invasive techniques, so we damage you less. We cause less of an inflammatory response, fixing these very difficult problems to your body. So you can get up the same day of surgery despite having this stuff done. And we can get you out of the hospital sooner, so you don't have to go into nursing homes and rehab places and so on. And we always say, motion is lotion. So the faster I can get you up moving, the greater evidence we have that we do a really good job for you going forward. So what do spine surgeons do, right? If you get sent to a spine surgeon, what we do? Well, we really take very good care of people with both straightforward, simple stuff, little back pain, little leg pain, that kind of stuff, as well as very complex spinal problems. And we mostly try to stay conservative, right? The fact that you would potentially come to me doesn't mean that I'm going to chase you with the scalpel. We always try to exhaust all conservative measures before surgery would even be an option. But if there are mechanical instability problems or mechanical compression problems on nerves, you can imagine that injections, therapy, traction, chiropractic manipulation, and so on are simply not going to cut it when your nerve is crushed between different bones that have fallen together. So we're going to talk about that. We do sometimes very small incisions with endoscopes, right? So a little camera, like an arthroscopy of a knee, to be able to get a herniated disc out. We are very proud of really small incisions, right? Because small incisions mean that we hurt you less and your healing response is much less required. And then you see these commercials, right, of things like the Laser Spine Institute, which unfortunately turned out to be sort of a fad, and it folded around this time last year, actually. But not that this is reality for everybody, but we try to do less damage while still doing a very effective operation. Sometimes alternatives, however, need to be considered, and then we go into surgery, and then robotic presentations about anything robotically in the spine or in orthopedics typically involve implants. So we're going to talk about, putting screws and rods and all kinds of things, but I want you to also understand that the most surgeries we actually perform are soft tissue surgeries, where we take disc pressure off, we take herniate the discs out, we decompress nerves and so on. So not everybody who comes to us suddenly ends up with like a 10-level spinal fusion, right? But I think robotics have helped us tremendously to change the way that we do these very complex procedures, where usually the complication rate is a lot higher, which I will show you. And the robot presentation that you'll see today is also, you know, primarily about this kind of hardware. So so the robotic system is still something we do by hand, but the robot guides us in the operating room. And the system we're going to talk about is called the Mazor X. It's a system that you can see here that consists of a robot that is attached to the operating room table. Then there is sort of the brains of the robot that helps us plan the surgeries beforehand. And then there is something that helps us visualize the tools. And that's called navigation. And we're going to talk about that a little bit. That's now integrated with the robotic system. But you have to imagine that the robot itself, when we developed it, had no ability for us to see what was going on. We had to just trust the robot in its 3D coordinate system. So what we're going to talk about is, you know, this spinal hardware thing. And it used to be a big deal for us because putting screws and rods, even when I trained 15, 20 years ago, that was a big deal because it was difficult for us to put that in. But in fact, all the other things associated with spine surgery are far more important, such as you know, the safety and efficacy of getting your nerve roots decompressed, to get your leg pain better. And nobody really cared so much about the hardware, but we stressed about it in the operating room, because if you put a screw in the wrong place, you either pinch a nerve, you can wrap up a nerve completely, you can put a screw inside of a blood vessel. So we worried really about the hardware. And the technical ability for us to get better and better took a long time to place that, while all the other things that you were hurting from, like the nerve compression that gives you sciatica and so on, and can give people sort of a drop foot and weakness in their legs, is far more important to get fixed. So what we do, most importantly, is the right, and we do it in a very predictable way, and we allow, what I always say, the evidence to guide us in what to do. So I'm very proud to say that I'm an evidence-based spine surgeon. If there's no evidence for your operation, and I wouldn't do it on my mom or dad, I wouldn't operate on you for it, right? So we let us guide by evidence, but then this hardware thing always took so much stress from us that it was difficult sometimes to focus on the other things that were far more important during the cases. So we felt that, you know what, if we take the stress away from the hardware and we have robotics systems help us place the screws, we actually can focus that stress on these things that are far more important, and we do a much better job for you going forward. So that's where the Robotic Spine Institute of Las Vegas was born, together with Allegiant Spine, Nevada Spine Clinic, and then at Southern Hills, obviously, now here in your backyard, providing this unique opportunity. So where do we start? I think if you look at something and you want to learn from it, you always have to look at your history a little bit. So for a very long time, we were trained as open spine surgeons, right? So if you see somebody, or if you had maybe an operation, you typically got a midline incision on your back that was maybe a foot long, and we did open surgery. And we were really good at doing even complex surgeries, even in older people. But what we have to realize now, and that's sort of evident by your community too, right? Why do you live there? Because you want to be active, you play pickleball, you're in the pool. I mean, it's beautiful facilities, because the past 60 is the new 80, right? I mean, people want to be active. So I think we're obligated to make sure that we help you maintain that lifestyle, or even amplify it if you have some difficulty getting there. So if people have sort of a sweeping spine curve, we learned to become really good at doing this, but we always had to make a giant incision. And that's not as easy to get over as you may think. And then especially if people have to have revision surgeries, as you can see here, where we sort of add it on, and we add it onto the bottom, and there's screws in the pelvis and so on, and we do that open. And I hope most of you had your lunch already, but this is a picture what that would look like at the bottom of the spine. So this is literally a giant salad bowl size opening to be able to get that hardware in, to get the spinal nerves decompressed. And you can imagine healing this is, first of all, fraught with infection problems. There's a chance of about 5 to 8% for an infection. And then there is just all this material that turns into scar. And that's not ideal, because I have taken care of patients like this that had complete wound breakdowns afterwards and needed to be in a nursing facility for 6 months to let this slowly heal back together. And that's purely due to the fact that the damage that was done during the surgery, unfortunately necessary back then to put in the hardware and do the right thing with the operation, hurt the patient tremendously. So that's what we're going to try to get away from, because we realize that exposure of the spine, and closure takes a long time. It exposes a lot of tissue that is subject then to infection risk. There's a tremendous inefficiency to have to make a big hole to see the anatomy if there's other ways to be able to do that. The reproducibility is not always the same between me and my colleague over there and maybe the professor over at the university, right? It is a difficult thing to make it reproducible between people. And then there were accuracy issues placing the hardware and doing the right thing with the nerves, because you get fatigued. If you're 6 to 8 hours into this case, you're not as good anymore as when you started in the first 45 minutes of that operation. And when you do very difficult things, so fixing this problem where somebody couldn't stand up straight, you can see that there's a spine here that curves all the way towards the right side instead of that it's in the center. This patient already received a pain pump before. The bowels are full here with, unfortunately, constipation, because that comes with all the narcotics that were necessary. Those problems are very difficult to fix. And if we did that, and these are some of the study groups that I belong to, we unfortunately had to report maybe good outcomes from a spine standpoint, but the complication rate could not be ignored, because it was 29% in the first paper, 39% in the next paper, and even up to 42% with colleagues of mine that did the same operation, trying to help people with a really bad problem. But in the process, we unfortunately hurt them. I always thought unnecessarily, but we had no other ability to fix people like that. So we felt that, there's a better way to do this. So that's where minimally invasive spine surgery came from in the early 2000s when I was in Baltimore. And we did this because it was better for patients, right? And we started to see much improved outcomes when we minimized the trauma that we did to patients in the process of trying to make them feel better. Because everybody, my colleagues, as well as, all the patients I spoke to, that lessening comorbidities like bad things from surgery would be better. Shorter OR times are better, right? Less anesthesia, also for cognitive reasons, right? That you don't wake up like having forgotten your wife's name, for example. Those are bad problems from long-standing anesthesia. Radiation is bad, right? So if we could get away from radiation for all that time, would be significantly improving our outcomes. We don't want complications, right? You don't want to have even a bladder infection or so after surgery. But it turns out the longer you're under anesthesia, the higher the chance you even have for a bladder infection. That has nothing to do with what I do to the spine, but it has to do with the process that you had to go through for me to be able to fix your problem. We certainly never want to have to reoperate on you within the first 30 days or so, because then you might think, something must not have gone right. That's bad for your outcome. It's bad for our relationship. So we want to fix things, and we want to give you great longevity from what we do. And if we plan our surgeries better, we felt that, there's definitely something to be said for that we don't want to come to the operating room and not necessarily know which type of screw we're going to use, if we're going to put a cage in there, if we're going to do a 2-level operation or a 3-level operation. I always compare that to you imagine you sit in the Southwest Airlines, first row because you were the first guy on board, and the pilot comes in, but he happens to be from United. His tie is backwards. He looks all flustered. He has no idea where he's going, hasn't checked the fuel, and has no idea about the flight plan. I mean, you never want to go in a plane with that guy. So you don't want to have a spine surgeon who comes to the operating room anywhere prepared like that, as opposed to what we could do with robotics and planning our surgeries, have a whole plan that we could just step by step execute in a much more efficient way to make you go through surgery much safer. So everybody agrees with this, right? And then how do we start our journey to accomplish this? Well, we started this by, first of all, not making big incisions anymore, but starting to plan surgeries. And we started operating over wires, for example. So you can see here that we didn't have to make a big incision anymore, but we used radiology to guide wires into the spaces where screws needed to be placed. And then we guided the screws over the wires into the spine. So suddenly these incisions here, they look like altogether they would be the same thing as a big midline incision, so to speak, but the amount of dissection is minimal with this. So you just have a couple poke holes, and we put a little tube through that to get down to your spine. And then we're still able to do the same effective operation as what we had to do before with this big incision to actually look at the anatomy directly. So these were ways that we started. So these are some of the original robots. They were sort of duct taped together, and it was a wonderful time when we got the first one through the FDA, so we could actually start using it clinically. But since then we've come a very long way. So we felt that this was very applicable for all surgeons and patients, but the reproducibility of doing this was still sort of a handiwork, like a craftsman work we had to do. And if you put your screws in like this, and then you have to pass a rod underneath the skin and so on to connect from one screw to the next, to the next, to the next, is a skill that some people are much better at than others. It's like hand-eye coordination on the pickleball court, right? Some people are really good at it because they used to play tennis maybe, or they honed their skills from when they were younger. But for other people, it's much more difficult to do this hand-eye coordination. And the operating room is no different. You might think that, all of us are stars when we come out of our program. Well, even, I was very humble early on. There was a lot that I had to learn still as a trauma attending in Baltimore. So that comes with time, but I think that's not an excuse, right? If we have tools that make people out of the gate better already, and we can elevate the bar for everyone doing this, eventually we help you as our patient much more consistently throughout these operations. So how did we start with these wires, right, that I was talking about earlier? We utilized a fluoroscopy machine. So we call this a C-arm because the thing is C-shaped, right? There's X-ray underneath the table that comes out of the X-ray tube right here. It shoots through you as a patient, and then it goes here into what we call image intensifier, and it creates a picture. But there's different varieties of tables you need to use. You have to angle this a certain way. And then in the beginning, we drew lines on the patient to get just a bunch of pictures to figure out where the spine was underneath the skin in order to start operating on this. And this is like, 2000 to 2005 or so. If we did multiple levels, so this was a trauma case, and you have to do 8 levels, the amount of radiation was almost 4 minutes with the fluoroscopy machine. So that wasn't just bad for you as a patient, but also for us being exposed to this maybe 5-10 times a week, including as a surgeon standing close to the table, as well as my nurses standing around in the operating room. And yeah, we wear these special lead skirts and all this kind of stuff, right? But still the amount of radiation is not to be ignored that goes to our eyes and brains and so on. So it is a bad thing to have to use radiation. It is necessary, but less is more. So then we advanced doing these cases and say, although we have to do radiation, does it actually work? So there's something called damage control spine surgery. If people are really, really sick, so this is one of my patients with a motorcycle accident, of course, you can see here the spine is terribly broken, this patient is paralyzed, but if we don't fix this patient will never be able to sit up straight and will have tremendous pains from this. So in the past, we used to make, as we talked about, a large incision. We used to peel everything off the spine. It was like a 6-hour operation. But then we learned that with this X-ray machine, the fluoroscopy C-arm, and these wires, we could put in these screws with these tubes, put a rod underneath the skin, and without any difficulty, within 90 minutes, we were done. This is another example of a man who is very, very sick from an accident. So his spine is nearly fused, as you can see. Sort of, it looks like a piece of chalk. This is a special disease that some people develop. But if you break your spine, this means this is indeed as unstable as a piece of chalk would be that would be broken in the middle. And it's not just broken in one place, it's broken in 2 places. So the risk traditionally in the literature, if you turn these patients on the operating room table, the risk of paralyzing them during that process is about 50%, because it's so unstable. And the only thing that connects top to bottom is basically the spinal cord and a bunch of soft tissue around it, because the bony congruity is completely destroyed. So this is a bad problem. But if the patient comes with this in the damage control spine setting, because he also has an open brain injury, right? We had to pop his top here and just evacuate a hematoma. His left arm is crushed because he got hit by an SUV from the left side. His left leg is crushed. His tibia and his femur bone are also broken. He has diabetes, so he comes in with some medical problems, which is sort of unavoidable, right? When you get, a little bit older. He has high blood pressure. He's obese. He weighs 268 pounds, so it's a big guy. And he fractured all of his left-sided ribs. So when he was hit from the left side, as you can see, maybe all of his ribs are broken, and all this blood is extravasated from the ribs in his abdomen, in his chest. So this is a very sick patient, and it's impossible for this person to undergo a real big open operation. But he still needs to be fixed because he's highly unstable with this chalk-like bar in his back that is broken. So what we started doing with this, and this is one of the longest MIS cases that was ever performed. So this is a case from the thoracic forelevel, like high up in the neck, all the way down to the lumbar spine. And this is one rod that we were able to squeeze in here by utilizing special techniques and so on. And it only took us 2 hours of surgery, 120 minutes, but it took me 4 minutes of fluoroscopy to do this. So that's 4 minutes of the C-arm taking X-rays. And we felt that, we saved this man's life by doing this operation this way. but the toxicity of the radiation was a problem. So the method worked, but how to get there was still not ideal. So that's when we started to continue with our quest to do this better. And then there's something that's called navigation. So navigation is something that came up in the late 90s. It's called computer-assisted surgery. This was sort of the predecessor of robotics. So there are cameras that are looking down onto the field, and I'll show you some details that will be very educational. It's being utilized still in neurosurgery, ENT, and some in orthopedic surgery, and it's used for brain and spine surgery, as well as it's being utilized for knee and hip replacements with some of the other robotic systems that we have out there. There's a long history here starting in '95, and eventually it got acquired by the company Medtronic that also acquired the Mazor robot. And eventually it's called the Stealth Station. So if you're interested in this, make a little note, Stealth Station. There's very cool videos on YouTube and so on to look at this. But this was actually sort of taking the place of this fluoroscopy machine for us in the operating room. However, you need special tools that need to be seen by an infrared camera that is mounted in the operating room. There's a reference marker on the patient. So there's a little stick that comes out of the patient, right? We put this in your pelvis somewhere with a little fiducial balls on there, so it can be seen. And then you have this camera in the operating room, but there needs to be a constant line of sight from the camera to your field. So you, as a surgeon, have to sort of work around all these tools, because as soon as you obstruct any of these little, we call them fiducials here, the camera loses sight of it and you lose track of your instruments. So it works, but there are some drawbacks to it. What you can see here, I'm steering a tool, right? It has this fiducial on here, and I actually, when I'm tapping this in here, I have to look at the screen far away. So I can't look down on my patient, but I have to look here what my tool is doing relative to the anatomy, and I have to, in my brain, I have to put all these different cuts through your body together. So there's cuts that go from the side, from the top, as well as that slice you. And then if I put that together in my brain, I can move my tool, and it is sort of a craftsman type operation, right? I have to do this hand-eye coordination still, and the only benefit here is there's no radiation, but still it's somewhat difficult, and not everybody can learn this well. So this craftsman type thing this is a classic picture I always like to show. So these are some of my colleagues operating, and you see nobody's looking at the surgical field, right? They're working in this, 3 degrees or 6 degrees of freedom area in the Z-axis up and down, the X-axis one way, the Y-axis the other way. But they have to look at these screens to be able to coordinate where the tools are going in the patient. So again, benefit that there's no radiation, but the drawback that this is a very craftsman-like, very skillful type operation that not everybody can do. If we got when we got better with this, it did show that misplaced screws, that is what this graph is showing here. Misplaced screws is of course a big no-no, right? We never want to put a screw in the wrong place. So initially, without having any ability to see anything, sometimes up to 25% of the screws were not perfect. We got better and better and better utilizing these technologies. But what I said is this is a craftsman type thing, right? This is still something that you have to learn, and you have to do this hand-eye coordination. And it brings a certain amount of stress to you as a surgeon because it's still not planned. It is on the fly during surgery, a tool that helps us to achieve greater accuracy, but you have to be on your A game from 7 a.m. on Monday to like 7 p.m. on Friday to make sure that this goes well. So how can we benefit from this at greater clinical value and actually automate this process? Because if you have navigation only, right, for some of you that have been or maybe are still flying as a pilot, right? If you have navigation, that's wonderful. But if this guy is your pilot, you still might be somewhat concerned that these additional tools that are there might not get you all the way safely there. So then, putting all this together, right, we decided, you know what, we know where we need to go next. So then we started to think, okay, what is happening in the world around us that we could potentially learn from? And that's how we sort of came up with, what is minimally invasive spine surgery going to look like in 2030? And why don't we start that runway now, so we are very well prepared to incorporate what's going on in the world around us with machine learning and robots and all that, to develop something that is going to be really cutting edge, that is going to reduce radiation and increase efficiency, accuracy, and predictability of our surgery. So we started to look around, and what do you see, right? I mean, everybody has now, at least something robotic. Maybe there's an iRoomba or something like rotating around in your house, right? Maybe you have kids or grandkids that like robots and that have toys like this. When I go on Amazon, right, I mean, this is basically the first sheets that you see, right? The toys for Christmas and so on are all robotically driven. They have cameras, they respond to you and all these kinds of things. When I was in Northwest Florida, I lived next to Eglin Air Force Base, and you know that our armed colleagues in the force are having all kinds of automated robotic type tools that help protect us and keep us safe. If you drive a car, you know that all those cars are put together for 90%, right, without a human even present. So this is just one of those ways in BMW where they built the Model 3, and you can see that that gets done this way. And I was very fortunate to teach a lot in China, so they actually took me to an Electrolux air conditioning factory, and you can see this giant plant here, and they built 3 million air conditioning units a year here. They used to, in the building next door, require 3,000 employees for that. Now they need 4 employees. Now, I'm not advocating that robots should come in and displace us, right? And this is a whole different discussion, but I just want you to be aware, as most of you are already, that there is a movement in society to make repetitive tasks better, easier, more predictable, utilizing robotic technology of some kind. And I think it's silly in medicine if we close our eyes for this. We should not, right? If you want to have a cup of coffee, right, there's a lot of robot cafes nowadays popping up in different airports and so on. This is the one that was in Silicon Valley. So the Cafe X, you just swipe your card and you just get a cup of coffee, and it's predictable, and there's no waiting, and you don't have to worry about somebody who's disgruntled and unhappy. You get a predictable product, and that's just what's happening around us, whether we like it or not, right? And then some of you might know that the hospital here also has a Vinci Robot from the company Intuitive out of Sunnyvale. Very successful soft tissue robot. Works entirely different than the robot that we have for spine, but it's been very successful. And it's more like a very fancy drone, if you will, right? Because the robot itself only does things that the controller here, the surgeon that sits there, is able to utilize. But you have to imagine the tools that can be used for this are like less than 1/4 millimeter. And you can do really fine work, fine stitching with blood vessels and so on. And it's been very successful throughout. So we've learned a lot from what worked with that. And frankly, most of the people that were successful in building Intuitive then moved over to Mazor and were my colleagues when we built the Mazor X robot. So that's an exciting transition. So again, we said, you know what, how can we do this better? Minimally invasive surgery makes sense. Some type of navigation is cool because we reduce radiation, but how do we bridge all this together and make it more predictable? Well, that's where robotics came in. So we said, you know what, we're going through a very exciting transformation, and we have robotic systems now that help us in the operating room. And I think as surgeons, we should be the developers of this. We should be the front runners on this, because again, we have to treat you. So this is not a, I think, engineering driven thing. This is purely a surgeon driven thing, because we know what we need in the operating room to help you better. And I'm very excited that I was part of this development process. So we minimize fluoroscopy. The radiation goes away, we maximize the efficiency in the operating room, and what we want is reduce what we call outliers, like things that we don't want. If the robot helps us with that to make a more predictable product available for you, I think then by hurting you less throughout surgery, we really have a winning thing here, and not just sort of a cool, sexy type new tool in this robotic scenario. So the early robots we had became very accurate already. We were like up to the 99th percentile, very consistent. And then the tactile feedback that we utilized while using the robot prevented us from doing anything bad, even in the 1%ers, right? But the robot was incredibly accurate from the beginning. And my transformation started really with something called the Renaissance. So if you want to write something else down, there's a lot of stuff about the Renaissance, which is a little robot that maybe at some point we'll talk about. And then we developed something called the Mazor X. So it doesn't say Mazor 10. Some people confuse that, but the Mazor X is the X is truly the system. And I've done about 1,000 cases at that point. In addition to doing surgery in the prone position, right, where you would lay face down on the operating room table under anesthesia, we also developed a system where you could just lay on your side. If we operate from the flank, some people have had surgery, maybe perhaps like that you had an operation from the flank, and then we can actually keep the patient in that position and put in the screws from the back. We don't have to turn you and flip you and so on in the operating room. And the Mazor X Stealth Edition, write that word down, stealth, along with Mazor X, if you want to look more up about this, is the system that we have here. And that's sort of the cat's meow. It's the most modern system with the greatest capability and the greatest accuracy for our surgeries. only at Southern Hills at this point, and in collaboration with what we do. So why do I believe that this automation thing can improve struggling surgeons, right? This is not just for me, this is for the surgeon community around. And how can it make a great surgeon, people that do a really good job already, even better and faster? Well, because of great evidence. I said before already, right? We like to treat patients based on the evidence we have. We don't just make it up and suck it out of our great thumb to come up with an operation, but we rest on shoulders of people before us that have been able to gather data that we now contribute to, and we show evidence that it's better. And this is one of the studies that we did when I was in Florida. So we took a 705 group of patients. So this is a large group of patients, and more than half of them had a robotic operation. About a third of them had what we call a freehand MIS procedure with these like wires that you saw earlier where we used radiation. And then we had some open surgeries also that were done by some of my colleagues that were better at that, right? And we compared all these people. And I don't want to bore you specifically here with all the statistics that we did, but there is something called like an odds ratio for complications and for revision. So the risk of a revision doing robotic surgery versus the old guide wire type surgery, the risk was threefold less in our robotic group, in both against the MIS group, the wires, or the open surgery. And if we look at revision surgery 2 years down the road for things like, you know, a disc adjacent to the levels where you had surgery that potentially would degenerate, that risk was almost fourfold reduced in the robotic group. So it's not just that the robotic arm moved a certain way, but we just were better prepared for surgery, and we did a better job with the constructs that we created in a much shorter period of time. So then the risk for complications, readmissions, and so on significantly goes down. So we saw this complication and revision reduction, as well as that there was about an 80% reduction in radiation during surgery. And this was the early generation robot that we had. So we already said, hey, you know what? This is not just a fad. We actually are showing that we hurt patients less in the process and that we have a more predictable result. Then we did a prospective study where we looked ahead, right? So people were enrolled, and we amplified the data on this. And the main thing what we saw, and the graph here behind me is the most important thing probably from this talk, is that if you have two groups of patients, one of them is robotically guided and the other is fluoroscopy guided with these guide wires, right? That we were so proud of, that we had developed too, and we were really good at. If you look at the first 90 days out of surgery, like the first 3 months, basically. This is we call this a survival graph without complications. So all these people lived, right? But the green line here shows that there were only very few people that had a complication in the first 90 days, not just associated with the spine, but also associated with maybe a fall at home and a readmission for the flu and like other things that happen because of the damage that potentially was done to you during the surgery, right? Because it's you know, not free of any complications if you have anesthesia and so on. But just having the robot and being better prepared gave us a complication rate that was maybe like 3% versus the group that had this guide wire type operation with the X-ray that we used for so many years before. They almost had a 25 to 30% concern in that first window for the 90 days. After that window, everybody becomes sort of equal, right? Because there are things that happen to you. You might have a fall, whether you had robotic surgery or fluoroscopy surgery when you stepped out of the car and there was a puddle or so. So those things are very difficult to account for. But the first 90 days, and especially that first month after surgery, there's a tremendous difference if you have a robotically guided operation versus the traditional surgery that we did with the minimally invasive approach already. So I think that's classic and easy to understand. So the greatest benefit is in this perioperative period, is what we call, because of the precision, the predictability, and the simplicity really of what the robot can help us with during surgery. So we get better at all the other things that we determined in the beginning of the talk were far more important than just putting in the hardware. So now, and how do we do this? We get a CT scan on you to be well prepared. So the CT pictures get loaded up. I'm identifying sort of the area that we're operating on. Then the spine actually gets cut in the individual vertebral bodies by the robotic system. And these individual vertebral bodies are the ones that we're going to work on to put the screws in. So the computer displays the individual bone. So you can see a vertebral body here. And then I can use the software to put in my screws virtually and then have the robot help me execute that during surgery. So the way that it goes is like this. So I hope you can see here that there's 2 screws in here. I have a screw on the left side and on the right side through a specific area of bone, typically where we place our screws. And I can move that screw around. I can put it a little bit more straight up. I can manipulate it all different ways. I can increase the diameter of the screw, increase the length of the screw. I can see what any kind of manipulation would do to the nearest neighbor because I'm building my construct. I can show you as my patient, you know, this is what it's going to look like when we're in the operating room. So virtually, I do all of this work. Then I can attach virtually towers to my screws, and I can identify where these skin incisions would be. So I make them all in sort of the same spot. So we make a nice cosmetically appealing result, and we have to do a lot less soft tissue dissection. And then we can eventually address the entire spine and basically build the whole construct as well as your correction that you may need in case that your spine has any kind of deformity. And we do all this the night before. It takes me about 45 minutes to an hour to do. And then we have the robot in the operating room to help us execute, and I'll show you how that goes. So we cut the spine in these slices. We do our planning, and if you have large areas of bone where you go through, it's really not that different than when we used to do it with the guide wires. But sometimes, and this happens to be in the thoracic spine, sort of right behind your heart, if you had to have an operation there, the bony column to go through basically doesn't exist in that area. So this is a very difficult operation for us to accomplish safely because the spinal cord runs here and your aorta that pumps the blood around from your heart lives right next to this. And I have to put this in here, and I have about a 6 millimeter window. So it's just over 1/4 of an inch. If you cannot see beyond the superficial anatomy, it is very challenging to do that. So this is where that stress level again comes in that completely goes away with the robot, because I'm putting my screw trajectory here, and whether this was a very large block of bone or a tiny little sliver of bone, the robot helps me to achieve that trajectory very predictable over and over again. So with that, I want to show you here what it does if I place my screws 2 different ways through that column of bone. The benefit of the planning with the robot comes in when you start to build a construct, because both these screws are okay, and they would have been totally the way that I would have done it with the guide wires before. But if you imagine looking at these 2 screws in this trajectory where I have to put my rod maybe underneath the skin, it is going to be very easy on the left side to pass it because all the screw heads are lining up nicely, what you intuitively would want, but it's a difficult thing to achieve in surgery unless you have a robot, because then you'll never place these screw heads in a way that you can't connect them with a rod. It's very difficult to zigzag a rod through something if you can put those screw heads all nicely in line and connect them from one to the next to the next. So that's a big benefit of the robot, and especially not for 1 or 2 level surgeries, but if we do these surgeries on children with very difficult deformities, this is a very challenging operation, as you can imagine. So good luck putting all these screw heads in a way that they're attached by one rod when you're done with surgery. So imagine how the robot can help to make these complex things a lot easier for us, because otherwise your cognitive load, your cognitive ability here to accomplish this is tremendous, and the robot can really help us with that. Now, and how does this work? This is a picture of the Renaissance. So this is how we started with, actually, this was the robot before. And if you look this up, you'll see Renaissance, and you'll see a bunch of videos with this. And now we've made that into something from here into something a lot more desirable, similar to sort of, you know, where you choose to live, right? I mean, you do that for a purpose because it works better for you. Same thing that we have a better robot because it works better for us. So I want to show you this video. And so what's new for spine surgery in Las Vegas, right? I mean, the answer is like robotics is here. And how do we do this? So this is the system that we talked about. It's a robot attached to the bed. It's going to be sitting next to me in the video. You'll see it is attached to the table. So I would be standing here and the robot arm sits over there. And then the control unit is in the corner that I used for my planning of surgeries. So you see me standing there. The robot is fixed here. So the first thing I do, I attach the robot to you as a patient. So you become one unit with the robot to improve accuracy. Then we perform a very quick surface scan over the patient, because the last thing I want is that the robotic arm is going to run into the patient, right? I don't want this arm to ever touch you underneath this drape here. So we call this the work volume. This is the space we allow the robot to safely work in. And it creates a true like 3D surface model of you as the patient on the table. And then we point the robot to an area we're going to operate in, because the robot doesn't know where you are at this point, right? So we point the robot generally to the area where your surgery is going to take place. And then we only have to take 2 X-rays in the operating room to match your spine in the operating room to that plan that I created the evening before. So we get an X-ray with this C-arm again, right? But we only get 1 shot. And we have the robot hold a little tool in space here to link the robot coordinate system to that picture where your spine is going to show up. We get a picture in one plane here, and then the robot is directing us in the other plane. So in 3D, we know exactly where your spine is. So this is sort of the setup that we utilize. It takes about 6 minutes total, and then we're off to our surgery. So we get this, what we call an oblique image. And then there's 2 images. They get put together, and they get compared to the CT scan that I used to virtually place your screws. So you see these 2 pictures that we just took. They're put together. They're related to this thing that the robot was holding. And then here, I'm going to be able to see how well this matching process has occurred. So I still stand between the man and the machine, and I'm going to confirm that, yes, the matching process was perfect. So that's what you can see here. I see the CT scan and the fluoroscopy picture flashing back and forth, and it shows me exactly that we matched this properly. Here we look one more time at the skin incisions, making sure that we don't have to make any modifications. And then we're going to do surgery. And we're going to do surgery with just little poke holes in the skin. So you don't have to look away. This is not gruesome or anything like that. We're just going to poke a couple holes in the patient. First, we put a little numbing medicine in there. So we make sure that there is even less discomfort from this after surgery. And then I have the robot guide me straight down into the spine with a knife to the starting point of my initial screw. We dilate down through the muscle. So we make a tiny poke hole, right? There's no blood or nothing. We leave a little tube behind that then accepts what we call the drill guide, because eventually you have to drill a hole through there, right? I tap that into the spine ever so slightly. So there are some teeth on there that hold it nicely in place. And then I take a drill and I drill it in there just over 1 inch. So it's called like a starting point for eventually where we put the screw. So I put that in there, and then we have a tube that has the same diameter as the drill, but it's hollow. So through that tube, I put my wire, then I pull the tube out, and then the wire sits in there. So this took maybe 40 seconds. And before, this would have taken at least 10 minutes. And it took my skill to do this to make sure I avoided blood vessels and nerves and spinal cord and so on. So we'll do it one more time. I made my incision already, right? We put the soft tissue guide back in there. Then we put the drill guide in there that you remember, right? I tap down, so it's, all right. Not sure why that stopped, but okay. So that's our first wire. So we'll continue with the second wire. We do the same thing. So we drilled the trajectory already. We take the tube out, we put a wire in there, and then we could potentially do the next level and so on. So it takes about 40 seconds per pedicle. And the only thing we have in there is these wires that we use no radiation for. We had no line of sight issue with the navigation. And we have a very predictable placement of these wires through the individual areas where we were supposed to place those screws based on the CT plan that I used the day before. So we then put the screws in there. And as I said already, right, the way that we plan this makes it easy to put rods underneath the skin without having to make a big incision. So we put these, 2 pedicles, these 2 areas together, and did that with, like less than 2 minutes. So far we've put in, about 8,000 screws. We've never put a screw in the wrong place. And this has been a very predictable way to build from this system that you just saw, the stealth edition that we now have at Southern Hills. So I told you I was going to teach you something also instead of just showing what we can do, right? And what I'm going to teach you is something called the cone of economy. And the cone of economy is like if you had an ice cream store, right? This would be your cone of economy. but you don't have an ice cream store. You sit in Regency and you're watching me. So what we're going to talk about is the cone of economy in spine. And the cone of economy is this conical space in which it is comfortable to stand up straight. Like the way that I'm standing in front of you, right? I am well balanced. It doesn't take me any energy to stand up straight. And it's very comfortable to be in this upright position because we are so well balanced because of the way that our brain works. It takes very little energy to be in the middle of this cone. If you go and you sway a little bit backwards or forwards, it takes a little bit of muscle force, right, to prevent you from going further than sort of out of this cone. And your cone is like an oval, right? Because your feet are not just one, but there are two for most people. And you have a little bit of an ability to correct from left to right that's greater than your ability to correct from forwards to backwards. But this is the cone in which we are comfortable standing up straight. And it turns out that the outcome of a spinal reconstruction for you is directly related to your ability to stand up straight after surgery. So if I fix your spine in a beautiful hardware, all kinds of complex stuff, tiny incisions, but you're like this, you are never going to do as well as something that maybe looks ugly on the back, which we still don't like, but in which you are standing up straight, because your outcome like this is going to be so much better than when you're sort of still halfway leaning one way or the other after a spine operation. So this is the goal we have to do, in addition to all these hardware things, to do with the robot a better job at planning to get you upright. Because if you go to the store later this afternoon, you see tons of people like this, and they have what we call their plumb line, right? The connection between your neck and your thoracic spine. That plumb line leans way forward. So if your center of gravity is in that direction, you are leaning forward, and you need to have like a shopping cart to comfortably stand up straight, because you can't hold yourself up with your muscle force in this position for a long period of time. This is a classic patient. She had a bunch of surgery done before without any hardware. They just took pressure off her spine. She lost what we call lordosis at the bottom of the spine, right? The way that your spine is supposed to form. And she was standing like this, and then she compensates for her plumb line being forward by bending her knees, right? And I can't show you that because you can't see my whole body, but you can understand that if she would straighten out her knees, her body actually goes more forward. So this is one of what we call a compensatory mechanism to sort of cheat if your spine is forward to still be able to stand up straight. And sometimes when we have this here, we're going to look at the correction we're going to do to this lady later on. Remember this picture here, because sometimes things get a lot worse, right? So this poor lady had multiple spine surgeries. The hardware is actually sticking up out of her back here. And we're going to show this case a little bit later too, how the robot helped me to fix these kinds of problems. We want to also make it a little funny, right? So I want you to understand this ability to stand up straight really, really well. So I thought to put this video in here because it takes our brain to stand up straight, right? If your spine is okay. If your spine is forward, you certainly need your brain for this compensatory mechanism to work. If you drink too much, your brain doesn't work all that well. So this man got pulled over. He is somewhat intoxicated, and he's being asked for his driver's license. So he tries to look for it and loses it. It falls on the floor, and he is not well balanced in space. So he hits the wall in front of him, right? Because his brain is not able to compensate for this forward position. And then he tries to use compensatory mechanisms. And you can see here that that doesn't go that well either, because he's overcompensating and hits the deck behind it. So I want you to not just laugh at this, right? But I want you to understand how important the ability to stand up straight is to not damage your walls and all this other kind of stuff, right? So remember that lady who was standing forward? These are her x-rays, and her spine is literally, if I can show it, and you can see this, her spine is like this. So unless she uses her knees, she cannot stand up straight. So in addition to making a plan for the hardware, what I can do with the robot too, I can recreate the shape that her spine needs to have to get her comfortably upright. And I can't just recreate this by telling the robot, hey, where does it need to be? But the robot will actually tell me now, because we've taught the robot, that I have to put cages in here, that I have to distract the front of her spine first. And then when I flip her over, I can put these screws in here and have restored the normal C shape of her lumbar spine. far more important than how these screws would all be pretty and go in there in the right place and so on. There's a lot more to the robotic systems than just helping us guide hardware safely. It actually helps us to correct your spine and bring it back into an anatomical position. So if I know that this is what I need to do based on my pre-planning, I go to surgery and I first put cages in the front of the spine, as you can see here, before I put all that hardware in to recreate this. And how do I do that? We go from the front and we have little blocks of bone that we put in between the vertebral bodies. And you can see that the C shape that I was required to recreate in this moment got nicely restored. And then when I put my hardware in there, it's merely just a tension band because my reconstruction of the spine was all done in the front. So yes, this is a spinal fusion because the patient has only pathologic motion and a deformity, but it's not really a fusion. This is a reconstruction. We put the patient back up where the patient belongs, and the outcome of this operation is predictably 92% good to excellent or better. That's what we know from all the data that we've gathered through hundreds of cases now, right? So sometimes these things get a little bit more difficult, and it's not just 2-3 levels, but we do, in no disrespect, older people with these deformities, sometimes very complex surgeries that now have been simplified for me in the operating room because I did all the hard work already the night before planning this virtually with the robot. And then this might look a little imposing, right? But for us in the operating room with the robot, it's just as easy, so to speak, as what we just saw with those simpler cases. It leads to lots of wires initially, but now we have a much cooler tool to help us put these screws in there with the Mazor X robot. And then it is still my skill now to pass these rods underneath the skin. But obviously, as you can imagine, we're working on that too, to help the robot help us put these rods in there underneath the skin without making additional incisions. And we can do even very long constructs predictably with the robot this way. So the automation that we have for these MIS techniques that are now amplifying what we do for patients, I want to illustrate with just 2 or 3 cases before we're done here. So this is a 68-year-old gentleman. He had multiple prior surgeries. So he had what we call a multi-level decompression. They took the pressure off his spine, laminectomies. You may have heard that word. He had some dural tears because there was some scar and so on. And at one point they fused his spine here. But the rest of the spine here is like exposing all of the nerve roots and so on. Unfortunately, when this man stands up straight, his spine is not what we like it to be, but because his prior open surgeries, the muscles are no longer able to support the spine. So he went more and more forward and can only stand up straight for 2 or 3 minutes. He has to use a shopping cart, he has to use a cane, and he can walk maybe 200 yards comfortably, but then he has to sit back down. As soon as he sits down, his pain goes away because there's not a lot of nerve compression per se, but there is inability to hold his body upright. His plumb line, like we talked about, right, is way forward because we like that plumb line to be somewhere around the middle of your body. So he gets an MRI scan. There's various problems on the MRI scan. We don't want to belabor too much, but I want you to see that when he's in the scanner, his spine alignment looks quite a bit better because gravity is no longer pulling him forward because these discs have no function anymore. They are just sort of placeholders there that collapse when he stands up straight, and when he lays on his back, they open up a little bit and allow the spine to somewhat reconstitute, which is good for me because now I know that with the robot, I can take these discs out beyond the area where he had prior surgery, and I can put cages in there. I can do things to restore the normal alignment of the patient. So this is what it was standing up, right? And this is when the patient lays down. Now then we go to surgery, and I do exactly what I just said. I use those disc spaces with these collapsing discs, and we put very fancy 3D printed titanium material in there. But we don't do that to make the picture look pretty. We do it to restack the spine. So I do it at the top and the bottom via an operation called an ALIF, an anterior lumbar interbody fusion. That's what the bottom 2 levels are. And I do a lateral operation, what we said earlier, right? Through a little flank incision at the top part with these titanium materials that sort of look like spongy material, but it's actually very firm because it's made out of titanium, but it allows bone to very quickly grow through there. So I do this on, say, like a Wednesday, no big deal. Patient walks within 5 hours from surgery. 100% of my patients get up within 5 hours from surgery because motion is lotion, we say jokingly, right? But it's clear that if you get people out of bed within 5 hours from surgery, their complication rate drops by 50%. So it's important for us that I don't hurt you too much during surgery. So I actually can get you up and walking very quickly, but 100% of people walk within 5 hours. So then the next day on Thursday, I get the patient up with physical therapy. I get a CT scan on him, and you can see, you know, these little cages that we have put in at the top 2 levels. You see the cages at the bottom. You can see that, you know, all this area he had surgery on before, right? Normally you have these spinous processes, these bumps on your back. Of course, he didn't have any, right? And he had no muscle left either to keep him upright. But we get the CT scan. Based on the CT scan, I plan my surgery, and I can verify that the realignments that the robot and I had predicted before, that we actually achieved that with our surgery in the front. And we look at the skin incisions also to make sure that everything's okay. Then we take him to surgery on Friday. So there's like a day of rest in between, meaning your anesthesia risk and so on goes down tremendously. It's much better to have 3 hours and 2 hours of anesthesia than to have 6 hours all at once, right? So you can see here, I put the screws in on one side already. See, there's no blood loss. There's no big incisions. It's all just little poke holes that I was able to do with my robot friend here. You can see me firing screws from the right side of the spine all the way over towards the left side into the pelvis. Again, this used to be like a big dissection for us in the past. Now we don't have to do it anymore. These are the final x-rays, and maybe on this view, right, from the back, it all looks great. But far more important is this picture, right? Because we talked about the cone of economy that I tried to teach you about. My purpose is not so much to put the hardware in correctly, but to restore the alignment. And the robot helps me to completely avoid this old hardware that in the past we had to take out and we had to hook into, and we didn't really know what to do with it. With the robot, I respectfully ignore it. I do a much better operation in the front, and I sail my new hardware right over the old stuff that's in there without having to dissect any of that. And we just keep it in there until this all becomes nice and stable. And then you remember what he looked like before. His plumb line was way in the front, and now his plumb line goes anatomically perfectly through the part where it needs to go. So this is not because I'm suddenly a better surgeon. No, I have a tool that can predict for me what I need to do in the operating room. I'm still very skillful in executing it, but in the end, I have a predictable outcome. And it's not like, well, I hope when the patient stands up straight that everything's going to be okay. I don't want that. I want you to leave the operating room with me, and I can predict that your alignment is going to be okay, that your screws are in the right place, and I want to do it in a very efficient way in the operating room. And that's where robotics helps us. Not just cool and sexy in the operating room. No, it's a tool to make me a better surgeon, to help you more efficiently. So back to the elderly lady we saw earlier leaning forward, right, on her walker. This is what her spine looked like. After a couple minutes, she would lean even more forward, and you can see that the hardware here actually is the hardware that's poking through her blouse here even. That's how prominent it had become. And you can imagine, well, you can have no life like this, right? So again, this is a little bit more complicated, but again, the same idea. This is like for the planning purposes, the idea of what this would look like with these cages. We do the same operation. You see these 3D printed titanium cages in there, similar to what we just saw before. Because this is such a big correction, we put these little plates and screws on there to make sure we hold things for the day in between. Then we plan her surgery, and then eventually, a little bit more complicated than what you just saw, right? Because there's a lot more that's necessary, and we need some additional strength in our system to hold her body up. But the system is otherwise executed the same way. And she gets this operation largely percutaneously, right? Little poke holes, very little big incisions. And she goes from what you see over there to what this looks like. But most importantly, on this picture, she goes to a nice, upright, normal alignment. And this is her about a month out from surgery. So suddenly I get these people that, you know, stand forward like this before. We preferably say we cut you in half and we put you back together. That's not entirely true, right? But you can imagine that the dramatic difference that you see from where she was to where she is now is you know, life altering for these people. although we do a lot of these surgeries, right, consistently, this is my data of the deformity surgery just before I left my past facility, and they kept really close track of everything. So we did about 250 of these deformity cases, complex things per year, in addition to another about 200 relatively more simple cases. But the hospitals are interested in complex cases, right? So they watch you as a hawk to see what surgeons do a good job, what their length of stay is, and so on. So I think this is helpful to see, because this is my consistent volume. And as you can see, over 6 months, 126 complex cases. So it's about 250 cases a year, right? If you look at my length of stay, which is the orange line down here, it says observed, so that's the surgeon, versus expected. So this is the national average for the same exact type surgery. So it's not that these surgeons did a bad job, they just do it differently. And suddenly it shows that those people stayed in the hospital an average of 4 days, and my patients were only in the hospital for 2 days. More importantly, complication rates. We talked about these numbers before a little bit. This is the national average for exactly the same surgeries as what I just showed you. And it's about 16%. My complication rate is 1.6. And the hospital, this is hospital data, right? I didn't make this up. This is what the hospital collects on us. And then 30-day readmission rate. And we talked about that before, right? How the robot helps us early on to make you do better out of the gate. Expected readmission rate is 5%. So 5 out of 100 people typically come back within the first 30 days. Mine was less than 1%. So this is not just because I'm a better surgeon, but I have better tools, and I use it, I think, to the advantage of all of you if you have a spine problem, and we treat your pathology a little differently. The next best thing, and this is also why I was in Silicon Valley a little bit, is that what if we could combine what I just showed you now with something that, you know, is like X-ray vision. So there is something called X-Vision that we're actually getting about 3 weeks from now here also at Southern Hills. And it's a headset with a projection onto my retina, and I look with these tools, and we're going to go, you know, back a little bit in history here with these needles to get wires in and so on. But I look down onto you as the patient, and what I'm seeing is an overlay on your skin onto my retina of your spine. So basically, what I'm utilizing these tools for is to go straight through your skin onto the spine. And this is truly, that's why it's called X-Vision. It's truly perceived by me as if I have X-ray vision right underneath your skin. So this is going to amplify what I'm capable of doing. And you can imagine eventually combining these two technologies where I optically can see what the robot is doing will also allow us to get pressure off the spine, to put in our cages and so on, without having to make pretty much any bigger incision than what the size of the cage would be. So this is very exciting for us, and I'm so appreciative that Southern Hills understood this and that we have both of these systems available in just a couple of weeks. So what we talked about, navigation, robotics, right? It helps us because it's safer, it's more accurate, it's more reproducible throughout the whole week. It has reduced complication rates and reduced radiation. And eventually, it's not just more efficient for me, right, that I'm less tired because I have things that take over things from me, but it's much more economical for systems because we have fewer complications and fewer readmissions, and we can do more in that same OR time every day that's available. And most importantly, it's better for you, our patients, because we show that we hurt you less and actually do a more predictable operation. So I think if we embrace sort of what's going on, and that's why I'm here now in Vegas, if we embrace what's going on in a minimally invasive fashion with robotics, we are going to redefine the standard of spine surgery. And again, I've done more of this than anybody else in the world. So whatever I could potentially do to help you with your spine problems and get you maybe a little bit more updated and knowledge about this, that would be wonderful. That's the whole purpose that I'm here. So come visit us at the Robotic Spine Institute of Las Vegas. Come see us at Southern Hills. As soon as we can have the doors open again and can do this live, I can let you play with the robot, look through the goggles and use sort of this X-ray vision. And I think there's a lot of great opportunities coming. And again, I'm very appreciative for the opportunity to speak to you today. So come find us. And if there's anything we can do, we're here to help within probably just a few days' notice. Thank you very much.